The next speaker is Dr. Kowdley, Kris, who joins us again from Seattle. I'm thinking we should probably make Kris an honorary member of this society because he's here so often. But it's with great pleasure that we invited Kris to come back and update us on PBC and PSC at the liver meetings. Kris?
Thank you, Steve. Unlike Groucho Marx, if I'm invited to be a member of this club, I would gladly join. And my task is to talk about PBC and PSC abstracts from the liver meeting. And here are my disclosures. So let me talk about this. I'm going to spend a few minutes talking about the Cobalt trial and the challenges and opportunities with trying to do a phase 4 outcome study when a drug is already available using a subpart H or surrogate endpoint pathway. So as you all know, PBC is a rare progressive autoimmune liver disease that affects about 100,000 people, maybe 200,000 people in the US, predominantly women over the age of 50. Obeticholic acid received accelerated FDA approval in 2016 for the treatment of PBC in patients who had not achieved an adequate response with UDCA based on the surrogate endpoints as evaluated in the POISE trial. And the POISE trial used alkaline phosphatase of less than 1.67, maintaining a bilirubin of normal range and at least a 15% reduction in alk phos as a therapeutic endpoint in the study based on data from the Global PBC Study Group and UK PBC showing that elevated alkaline phosphatase was a strong predictor of long-term adverse liver outcomes. So when a drug is approved using the surrogate endpoint pathway, there is a requirement for a confirmatory trial using hard outcomes to then achieve a regular or standard approval. So this study was begun before obeticholic acid was approved for use for PBC. So Cobalt was a phase 3b/4 randomized double-blind placebo-controlled confirmatory trial that aimed to assess the efficacy and safety of OCA in advanced PBC. And the study was not successful because it was determined by the Data Monitoring Committee that the study should be stopped for futility, meaning that there were unlikely to be enough events and differences between the treatment and placebo groups to show statistical significance. So one of the reasons that this might happen is that if you have patients who are in a placebo-controlled trial who were actually sicker than the patients who were studied in the initial trial, on placebo, there's really nothing to prevent that patient from going to their local doctor and saying, Sam, check my labs. And if they seem to think that they are not on active medicine, drop out of the study and then ask you to prescribe the medication, right? So how do you counter that in a placebo-controlled trial when the drug is on the market? You could do it in a study in a country where the drug is not available. But even then you have questions because fibrates, for example, are now approved for off-label use. So one of the opportunities here is to then use external controls. And how do you use external controls to try to strengthen the placebo cohort to see whether there's a treatment efficacy? So Cobalt included an external control group as a second comparator arm to address the challenges in maintaining patients on placebo when a drug is commercially available. There are a couple of other wrinkles with the study that's important to know about. And so the primary goal was to look at the effect of obeticholic acid compared to placebo, plus standard of care and external controls on clinical outcomes. So the primary composite endpoint for the European regulatory agency was time to first occurrence of death from any cause, liver transplantation, MELD score greater than 15, hospitalization for complications of liver disease, etc. The FDA expanded composite endpoint was all of the above, including uncontrolled or refractory ascites, undergoing a TIPS, portal hypertension complications, and for patients that had not decompensated, progression to decompensation, or if they had not decompensated or had portal hypertension, progression to portal hypertension or decompensation. Okay, so that was how they determined that the drug was truly effective as opposed to just showing an improvement in alkaline phosphatase. So here's the primary endpoint using the European Regulatory Agency events. So you can see on the left is OCA treated versus placebo, and you can see the hazard ratios do separate. And when you look at the Cobalt intent to treat OCA treated versus placebo and look at the probability of events, there is a difference, but the hazard ratio did not achieve statistical significance. So then the HERO studies was done. The HERO studies is a external database using this Komodo Health Claims database. And so OCA was approved. It showed a 58% reduction in risk of death, liver transplantation, or hepatic decompensation in the open label extension. So that's the other data point that I'm not going to show you, is that we have the Cobalt trial, which is a placebo-controlled trial. There's also the original patients who were in that POISE trial who were then treated for 5 years open label. And in that 5-year open label treatment, compared to external untreated patients, there was about a 58% reduction. But there was not a control group there. That was an open label cohort. So when you look at the totality of the data, there's clearly suggestion that treatment with OCA would reduce adverse clinical outcomes. But we didn't have those data. So one of the ways to try to mitigate this is to use real-world data from this Komodo Health Claim database. Now, health claim databases have pluses and minuses, right? So they use ICD-10 codes. One of the disadvantages of these claims databases is that the data going in may not be accurate as far as diagnosis and clinical events. But one of the advantages of having a health claim database approach in a health system such as in the US is that it's based on billing and it's based on commercial insurance. So we are highly incentivized as caregivers and providers and doctors to capture as many of those events as possible so that we can get reimbursed. So that would be different if you have a nationalized or socialized health system where there may or may not be the incentive. So at least as far as clinical complication and events and burden of healthcare, we think this is probably a good way to go. So this Komodo Health Claim database was used to compare the effect of OCA on occurrence of death, liver transplant, or hospitalization, including inpatient, outpatient pharmaceutical data. And this comes from Quest and LabCorp. It's a commercially available database that anyone can buy. And they also used obituary searches to see who may have passed away. So here's the study. The key points of this study are there were 4,500 control patients from this database and 431 patients that were treated with obeticholic acid in this database that met the inclusion-exclusion criteria. So they took this database, took the patients from this database and extrapolated them to say which of those patients would actually have been eligible to be enrolled in POISE. So they contributed 12,399 and 431 indices respectively. And what they found with this external database was that treatment with obeticholic acid resulted in a 63% reduction in relative risk of death, liver transplantation, or hepatic decompensation. And it's almost exactly the same as the open label POISE data, which I presented at this meeting last year. So you can see the hazard ratio is 0.37, so there's a 63% risk reduction, statistically significant. And so the key takeaway here is obeticholic acid treatment results in a statistically significant, clinically meaningful 63% reduction in risk for these complications. And this real world data is consistent with both the POISE open label and the global PBC registry external controls. And then we went back and looked at Cobalt, and I had the opportunity to present this as a late breaker at the liver meeting. Look at the events in Cobalt in the patients who were treated with drug compared to patients who were not treated with drug. And the events rate is exactly similar to this. So we have now 3 databases. We have this HEROES database, we have the Cobalt study, treated patients with OCA, and we have the POISE open label, all suggesting that the risk reduction is about 60 to 63% with OCA treatment. Whether this is going to be sufficient from a regulatory perspective to give standard or regular approval of the medication is still not clear, and we'll see how things evolve. So there's two major phase 3 trials that are now fully enrolled with different fibrates, Seladelpar and elafibranor. And then there are several drugs that are IBAT inhibitors that are in development for itching. This is a novel agent called Setanaxib. This was not presented at the liver meeting, but it was presented at AASLD. But I want to present the background because the study design was presented at the liver meeting. So this was a phase 2 study, and this drug is a first-in-class selective inhibitor of NOX1/4. And the key point with the study is, for the first time, this agent suggested improvement in quality of life, not just pruritus, but possibly fatigue, which of course, as we know, who care for a lot of PBC patients, that's the number one symptom for which we don't have much to say except exercise and maybe try sertraline, which doesn't work. So treatment at 400 milligrams BID in the phase 2 trial suggested improvement in markers of cholestasis, but also, more interestingly, improvement in quality of life. So here are the data in the PBC-40 scores: placebo, 400 once a day, 400 twice a day. And you can see that not only does itching and cognitive symptoms improve, but fatigue improved. So at 24 weeks, patients treated with Setanaxib had greater reduction from baseline in mean fatigue scores compared to placebo or treated once a day, and similar observations with the emotional, social, symptom, and cognitive domains. And here's the fatigue severity subgroups. There's a lot of information on this slide. I'm going to summarize at the bottom is after 24 weeks, patients who received 400 milligrams twice a day of Setanaxib had with moderate to severe fatigue at baseline had larger reductions in fatigue scores compared to patients with mild fatigue. This was seen also in the other domains of the PBC-40. And it seemed independent of liver stiffness, which is a surrogate for liver fibrosis stage. So when you look at placebo versus 400 once a day versus 400 twice a day, you can see that at twice a day treatment with 400 milligrams, pretty significant improvements regardless of whether the patient had advanced fibrosis or not. So this is very exciting, and if it turns out to be durable and proven in subsequent larger studies and phase 3 trials, may provide another option for our patients with fatigue-dominant symptoms. So in the intent-to-treat population, there was moderate positive correlation between improvement in fatigue, changes in the other domains in the PBC-40, and this was also seen with improvement in itching. What are the limitations? Numbers quite small: 18 placebo, 17 once a day, and 17 twice a day, and was not powered for analysis of quality of life outcomes. So this was a secondary endpoint, and it may or may not be held up. But these data suggest that in addition to UDCA, adding Setanaxib may be an effective treatment option for improving fatigue, emotional, social, and cognitive function. And I think we should pay attention to what happens with the phase 3 trial. And the phase 2b/3 trial study design was presented at the liver meeting, and it essentially shows you what the plan is. Just like previous studies, they're going to do a 2b, they're going to have an interim analysis. If it's positive, they will have a seamless design into phase 3, and then they'll have an extension phase, et cetera. It's recruiting patients, and some of you may be contacted or may already be thinking about participating. And so that's that. Now, Seladelpar is a pure PPAR delta agonist. It's in a phase 3 trial. It was previously shown in phase 2 trials to show pretty significant improvement in alkaline phosphatase with 78% of patients in a phase 3 trial that was interrupted and is now started again and now fully enrolled, achieving the POISE endpoint. So instead of 47 or 48% with obeticholic acid, achieving alkaline phosphatase less than 1.67, with Seladelpar, it was almost 78%. And 40% of patients with Seladelpar actually achieved normal alkaline phosphatase after 2 years in an open label extension. This was looking at lipids. Now, of course, one of the liabilities of obeticholic acid, it has an adverse effect on lipids with higher LDL and lower HDL. PBC, it's not as much of a concern, but one of the possible advantages of fibrates is that they may have a favorable effect on lipids. So in this study, they showed that lipid profile of patients with PBC treated with Seladelpar in phase 2 and 3 trials actually improved with treatment. So here's the baseline distribution. And you can see that total cholesterol goes down, LDL cholesterol goes down, HDL cholesterol goes down, triglyceride goes down. It appears to be dose dependent, particularly with triglycerides. And when you look at patients without lipid therapy and with lipid therapy, there appears to be sustained improvement. So in this pooled analysis, they found Seladelpar treatment resulted in significant reduction in total cholesterol, LDL cholesterol, and triglyceride without a meaningful change in HDL cholesterol. And comparable lipid lowering effects were observed in both patients with and without being treated with lipid lowering therapy. Now, of course, we have the typical PBC patient that may or may not have risk factors for metabolic syndrome, may or may not have elevated LDL cholesterol. The typical patient historically used to be thin, have very high HDLs. We didn't worry about cardiovascular risk. But now with every patient having risk factors for NAFLD and some of these patients being diagnosed much older, we are worrying about their cardiovascular risk as a competing risk along with their liver risk. So it may be attractive to consider that this may be a favorable effect of this class of agent. So PSC accounts for 5% of liver transplants in the US. For those of us that take care of a lot of PBC, PSC patients, the MELD score is really not something that helps the patient. Because of course, as we know, their creatinines tend to be low. They don't get hyponatremic until it's very, very late. And the serum sodiums don't, as I said, don't become very low. And so the bilirubin has to do all the lifting to get them that high MELD score. So one of the challenges here is how do we look at this? So UNOS mandates, of course, the MELD score. Exception points are available, but this is not well standardized. And with the new allocation system, exception points are very rare to get. So this study really suggests that we need to find other ways of trying to optimize waitlist management for these patients, and maybe thinking about utility of exception points in PSC and immunosuppressed patients with autoimmune hepatitis is something that we should advocate for. And I think future studies should evaluate the potential impact of MELD 3.0 on waitlist mortality and transplant outcomes. And I think we should probably be more aggressive asking for exception points for PSC patients for these reasons. This was really more of a review, but I just wanted to, but it was presented at an oral session by Richard Kwon, and it was about diagnosis and management of dominant strictures and cholangiocarcinoma and PSC. And the summary here is, first of all, what is a dominant stricture? They tried to define this as a narrowing of a bile duct to less than 1.5 millimeters in the common bile duct, or less than 1 millimeter in the left or right main hepatic duct. So anything other than this would not qualify as a dominant stricture. I think it's helpful because it might provide a standardization for us in clinical trials. 15 to 20% of PSC patients will develop dominant strictures. 1 out of 4 would be malignant. So anytime a patient has a dominant stricture, I think we have to really do everything we can to try to dilate, brush, maybe biopsy through the lumen of the bile duct. Of course, we do not want to do a transperitoneal biopsy, because if it's a cholangiocarcinoma, then they're excluded from transplant, as you know. What are the risk factors at the present time for cholangiocarcinoma and PSC? Age greater than 30, new diagnosis. Concomitant ulcerative colitis is associated with increased risk, and male sex. Dominant strictures obviously present a diagnostic challenge. So here are the diagnostic tests that they are recommending. MRCP is the initial test. ERCP in the setting of high clinical suspicion. FISH should be obtained in every patient. So I don't know if you're doing fluorescent in situ hybridization at the time of doing ERCP or cholangioscopy, but I think if we're sending a patient for an ERCP or doing it ourselves, we should have the expertise to be able to do FISH. And intraductal biopsy with or without cholangioscopy should be considered. And of course, you never want to do a percutaneous biopsy in a dominant stricture. Cholangioscopy cannot be used for biopsy, but can predict malignancy with an accuracy of 77%. Just a point of note, this concept of transcriptomics in a spatial dimension is very interesting. This was, from a scientific standpoint, very attractive. And what they showed here is you can utilize spatial transcriptomics that allows you to capture the heterogeneity of the liver, which in PSC, of course, is so much more important. And so what they did in this study is they looked at 12 frozen tissue samples from mouse PSC models and looked at spatial transcriptomics and compared that to paired PSC samples from 2 patients with low and high disease activity. And what they found is extensive restructuring of lymphoid and myeloid compartments, significant increase in pro-inflammatory macrophages, and monocyte homing signaling was exacerbated, suggesting chemoattraction of infiltrative monocytes from peripheral blood. And so I think it's just something to pay attention to. I think from understanding the disease mechanism, this is going to be a very interesting novel concept. So disease progression was associated with a marked increase in collagen production. Well, that makes sense. Myofibroblast activation, extracellular matrix deposition and apoptosis, and localization of disease-specific pathways and cellular profiles in PSC differed in early and advanced disease. And this was the most interesting novel finding, was CD8 T effector memory and cytotoxic cells more abundant in disease cells, and changes in CD4 T cell compartment also observed. So the key takeaways from the study is you're going to see more of this kind of transcriptomic approaches using a global approach to interrogate multiple dimensions of PSC, and may help us identify therapeutic targets in PSC where we currently have very little understanding of even the basic disease process. So itching is obviously a big concern in patients with PBC, and this was a survey of gastroenterologists in the US about how they approach itching. And so 107 US gastroenterologists were surveyed. These were clinicians spending most of their time in practice, had managed at least 5 patients with PBC, been in practice for more than 2 but less than 40 years. And then they looked at symptoms. So this was the providers' opinions. Symptoms experienced by PBC patients in their practice, 1 out of 2 had fatigue, and 39% had pruritus. And when you look at the symptom impact on the patient, again, they felt that 59% of patients were impacted by the fatigue, slightly less by pruritus. So this is the symptom that we are noting our patients reporting to us. And this is unfortunately a symptom for which we have no specific therapy. Now, when you look at one of the points that's sometimes thrown at us is that we don't pay enough attention to patient symptoms or pruritus, but in fact, 91% of the gastroenterologists responding said treating pruritus was extremely important to them. When you look at what do they use to treat the pruritus, though, the single most common agent was antihistamines, which I would say probably not my first choice in treating pruritus in a patient with PBC, because it's going to make their fatigue worse and it's going to make their dry mouth worse. But I think it just shows how limited we are in therapeutic options. 38% using cholestyramine, rifampicin is used in 8%, 7% using sertraline. And then when you look at satisfaction with pruritus treatment, even though we're using antihistamines more, we're actually more satisfied with cholestyramine. And when you look at the impression of us, we do agree that 68% felt this was a high unmet need in terms of pruritus. So moving on to talk about more specific therapies for pruritus, there was the GLIMMER trial, which is one of the IBATs that is being developed, linerixibat. So these IBAT inhibitors, as you may know, target the terminal ileum, where enterohepatic circulation allows for reabsorption of bile acids, and by blocking apical bile acid transport, using these ileal bile acid transport inhibitors, you prevent or disrupt enterohepatic circulation, and therefore bile acids are excreted. This is just telling you about the phase 2b GLIMMER trial. And you can see here that when you look at the results, you can see that this doesn't project all that well, but this is a high disease burden population. And what they found in the baseline data from this trial of the ileal bile acid transport inhibitors is that many patients do not receive treatment despite a long history. Currently available treatments have varying levels of efficacy, and despite being on concomitant itch medications, many patients still report moderate to severe pruritus. So there is a high unmet need. And so the phase 3 trial with linerixibat is ongoing. There are long-term follow-up study to this phase 2b trial with open label treatment is ongoing. And there are other IBAT inhibitors that are currently being developed for PBC. So I think there is a high likelihood that in the next 2 to 3 years, we'll have these therapies approved, hopefully. Now, I was involved in this study, which was recently published in the American Journal of Gastro, with a very interesting compound, berberine. Berberine is approved in Asia for treatment of travelers' diarrhea. It modulates the microbiome and therefore may reduce entry of bacterial products into the portal vein, and also has anti-inflammatory properties and interestingly improves hemoglobin A1C in patients with NASH. I was part of the study with the high tide 1801 or HTD 1801, which berberine with the salt of urso called ursodeoxycholate, using this therapy for patients with elevated alkaline phosphatase and PSC. Patients were randomized and treated. This was right in the middle of COVID, so instead of 75 patients, we were only able to enroll 55 patients who were randomized and treated. They then went through 2 different periods of treatment, and we used 500 milligrams BID or 1,000 milligrams BID or placebo. And you can see here that there are greater biochemical improvements in patients who had elevated baseline alkaline phosphatase when treated with HTD 1801. And you can see that those that had higher alkaline phosphatase, more than 3 times upper limit of normal, had the greatest improvement. So the conclusions were berberine ursodeoxycholate appears to have good efficacy and safety. Treatment emergent adverse effects mild to moderate, cholestasis and inflammatory markers improved, and dose-dependent trend in reduction is approved. The main challenges here is that how do you do a study when patients are either not on UDCA or on UDCA? Do you have to wash them out? And then there's the flare. And then if they're treated, how do you know what's the berberine component versus the ursodeoxycholic acid component? And if they're already on ursodeoxycholic acid, then will you have a marginal enough difference from the berberine component to show a difference? Those are the questions that are very difficult to answer, but I would encourage you to read the American Journal of Gastro paper. In the interest of time, I'm just going to move on to this Canadian study about incidence and prevalence. And this just shows that the incidence and prevalence of PSC is actually increasing. And the conclusion was the estimates of the incidence and prevalence higher than previously thought, which may represent case ascertainment and PSC management. And there's no question that transplant-free survival is worse in this population. And then finally, we know about high-dose urso being associated with bad outcomes or increased risk of adverse outcomes from the NIH-sponsored trial that was led by Keith Linder, that I was one of the investigators of. And at 28 to 30 milligrams of UDCA, there were higher liver-related adverse events. The study was discontinued. We never understood exactly why this was. We did a post hoc study looking at microRNA profiles in these patients, and we had a subset of about 17 placebo and 21 high-dose urso-treated patients. And what we found is there were marked and clear differences in the group that received high-dose urso in terms of the microRNA profiles. There were changes in the placebo-treated patients that suggested inflammatory and cell proliferative processes. And in the high-dose urso patients, microRNA changes were suggestive of dysregulated cell cycle and inflammatory response pathways consistent with tissue injury. And the conclusions were high-dose urso alters microRNA, compared to placebo. That was very clear. It could be used to identify prognostic features in PSC, and we need to understand better about exactly how this happened. But there was no question that marked differences in microRNA profiles were found with high-dose urso compared to placebo. Thank you very much.